Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time. Note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Multiple Neuroendocrine Neoplasia, MEN1, and Pituitary Tumors, presented by Dr. Jamie Van Gumpel, a professor in neurosurgery and otolaryngology, specializing in endoscopic, open skull base focusing on pituitary tumors, as well as epilepsy at the Mayo Clinic in Rochester, Minnesota. There will be a brief delay while we change presenters.
Hello, everyone. I wanted to thank you for the opportunity again. This is my third time being fortunate enough to present for the PNA, and in the past, I've been able to present on things like large pituitary tumors, and just recently about how COVID-19 impacts your surgical procedure, and both of those were obviously larger topics. And today we're going to talk about something that's more subspecialized to a smaller audience, but I think still very important. You know, I look at the little bit of the PNA a little bit like the public radio, and that we should all try to contribute to the education. I know I watch these webinars quite frequently and learn a lot from them, and I think in this particular circumstance, I'm just trying to provide some data that we were able to accumulate recently about a specific disease that some of you may have and may not know it. And some of you may know that you have it, and how does it impact you? So as Danielle had so nicely introduced me, I'm working at the Mayo Clinic in Rochester, Minnesota. I'm fortunate enough to work with a huge cadre of excellent additional clinicians. And most importantly, in this particular aspect, I work with a large group of endocrinologists as well as general surgeons that take care of a lot of these diseases. We're going to concentrate today, however, on the pituitary related aspects. And the objectives I have for you are that, you know, as many of you on this talk today have a pituitary tumor, some of you actually may have MEN1 and are unaware that you may have additional tumor, have the potential to have another tumor, although this is a very uncommon disease. And those of you that have MEN1 or multiple endocrine neoplasia type 1, it's important, I think, to understand the pituitary impact and how this disease may be special compared to just your run-of-the-mill idiopathic pituitary tumors. I have a couple of disclosures. None of those are pertinent to this talk. I'm funded in my NIH in R01 funding from Medtronic, and I have stock and company ownership in device-related companies, Neuro1 and Cadence, that we started, which are related to epilepsy and not related to, again, to pituitary-related diseases. This is a slide that I'm particularly proud of. I've been fortunate enough to present in our MEN1 seminar at the Mayo Clinic over the last 10 years with multiple individuals. But in the upper left-hand corner, this work takes me all the way back to 2003, in which I worked with Dr. Herb Chen at the University of Wisconsin, working on parathyroid tumors and neuroendocrine tumors. And I've carried this through my career as a specific niche interest. Because I find these diseases so fascinating, and been fortunate enough to cover these over the past 20 years of my life. So what is MEN1? MEN1 is sometimes called Werner's syndrome. So if you look around the internet, it might come up underneath that. It is a rare disorder that causes tumors in endocrine glands, such as parts of the small intestine and stomach. In MEN1, the endocrine glands, usually the parathyroids, are the most common, the pancreas, the pituitary, grow tumors and release excessive amounts of hormones that can lead to disease. However, most of these tumors are benign, and most of the disease that we see from these is from the secreted proteins from these tumors. MEN1 has, in those situations of hormone excess, can cause a wide variety of signs and symptoms like tiredness, bone pain, fractures, kidney stones, stomach, and intestinal ulcers related to the pancreatic tumors. And although MEN1 cannot be cured, regular testing can detect problems and doctors can provide treatment as needed. MEN1 has its genetics are in that it's on 11q13, so that's a chromosome arm. There's a particular protein called menin, which is a classic tumor suppressor gene. And this is an inherited disorder, meaning that people can have the gene and pass this on to their children. And each child that receives this has about a 50% chance of inheriting the gene and therefore developing the disease down the line. So what menin does is it actually causes the cell to be inhibited from dividing more frequently or making too many of one particular cell type that may be secreting something like parathyroid hormone or sometimes in pituitary tumors, ACTH or IGF-1 or these things that cause Cushing's or macromegaly. So who should get tested? Well, people who have 2 or more MEN-related endocrine tumors or other signs and symptoms of MEN1, as we've recently covered, and all first-degree relatives of a person who's been diagnosed with an MEN1 gene mutation. And these are the diagnostic criteria for MEN1, in that 2 or more MEN1-related tumors, so tumors in the parathyroid glands, pituitary gland, pancreas, or other parts of the digestive tract, which these tumors are commonly called carcinoid tumors, or 1 MEN-related tumor and a first-degree relative, which would qualify as a parent, a brother, or a sister, or a child who've been clinically diagnosed as having MEN1. You may also develop an MEN1 mutation or have it identified, and even if you have no signs of tumor, you would be considered at risk because this is autosomal dominant. And to the right of this slide, you can see the blue represents a carrier or an abnormal gene, and that mother in this particular circumstance has about a 50% chance of passing that allele on to the child. Now, that allele itself does not cause a disease, but eventually what happens is this other gene becomes weakened over time or has a mutation in one particular cell type, and that allows the tumors to grow. So what we're going to do is, I'm fortunate, as I mentioned, as we started out, to work with a large group of people at the Mayo Clinic that manage these tumors in this particular publication, which is published online currently, but will be out shortly in print. We detailed the extensive experience from 1970 to 2017 of probably the world's largest MEN1 institutional experience. We identified within that cohort of patients, 265 patients that were diagnosed with MEN1 at our institution and treated, and 158 or 59% of those patients were female. Of those 268 patients, 139 or 52% of those had pituitary adenomas. It was interesting that these pituitary tumors were more prevalent in women, 65% versus 35% in men. And again, that's kind of a play on the word MEN1, that it's more prevalent in women, but functional adenomas were more common in these particular tumors. So those are tumors that maybe send out prolactin or ACTH or IGF-1. And 49 patients, or 35% of those patients, underwent transfemoral resection at some point in time during the course of their disease. And this is a slide just to show that there's a lot of heterogeneity in these patients. But in those that we tested for the MEN1 gene mutation, about 89.1% of those patients demonstrated mutation at some point in time along the course of this particular gene. And that just shows that there are probably other pathway weaknesses that we haven't identified yet for this. But about 90% of the time, the test will identify a gene mutation that we can tell you, what your risks are of handing those on to your kids and so forth with this particular disease. And this table to the left, if you want to pause the screen here, you can kind of look this over. But it just shows you in patients with a family history of MEN1, an occurrence of an MEN1 associated tumor, so family history without a mutation, which one of those patients had pituitary tumors or parathyroid tumors or enterohepatic tumors within that subset. And similarly, with the other diagnostic criteria of greater than 2 primary MEN1 associated tumors, which ones those are and who they were without MEN mutations. Then in those patients with that MEN mutations in this particular paper, this shows you which one and what percentage of those patients had which mix of tumors. So you can kind of peruse this on your own if you're interested. The median age at diagnosis with MEN1 tumors is approximately 38 for females and 32.5 for males. I don't know if you guys can see this. I'm going to move this up a little bit because I'm not entirely sure you can't see this. The median age at diagnosis of pituitary tumor was in fact even was more around 35 or 36. I'm going to move my face around because I'm not sure where it is for you guys and ladies, but this particular slide shows that if you have a pituitary tumor, at what point in time does your tumor emerge up to a point of 100% of patients that have had these tumors? What age were they at? And it turns out a lot of these patients are obviously diagnosed by the time they're 40, but there are patients that have late progression and are identified later on. This particular slide covers, in that paper, the percentage of types of tumors in which we see. So non-functioning tumors, oftentimes these are discovered after the first tumor, 60 patients in that classic breakdown of 2 females to every 1 male. Most of those patients, or those patients' average age of presentation was 41 years. And interestingly, a lot of these patients had microadenomas. And I think the reason why we see that is that these particular patients had other tumors diagnosed, and these tumors were found on screening exams like MRIs. The other very common tumor that we see not only in MEN1, but it seems to be more frequent here than we see in spontaneously occurring pituitary adenomas is prolactin secreting tumors. And here again, we see that 2-to-1 female to male ratio. These tumors are diagnosed much earlier in 30s, and they're more common. They're still most commonly micro. And we'll cover this a little bit later, but these, as you're aware of when you're watching all the other PNI webinars, these are most commonly treated with medications. What is very curious about this disease, there's a high number or high percentage of patients with what we call plurihormonal tumors. And there's a slide coming up that will show the type of mix of tumors, which is really uncommon to see in spontaneous tumors, showing that this is probably a more primal gene activation with this autosomal dominant menin mutation. Growth hormone secreting tumors are uncommon, and as are patients with acromegaly or giganticism. And ACTH secreting tumors are uncommon as well, or patients with Cushing's, fortunately. And this is that slide that demonstrates that in those patients, so there's an abnormal number of patients that have multiple different types of hormones in these. So prolactin and ACTH in one patient, prolactin and growth hormone, multiple prolactin, growth hormone, and TSH, or the classic blue tumors, prolactin and growth hormone, and so on and so forth. What was really interesting about this group, and there's not a lot of data about when you find a tumor, what percentage of those tumors progress over time. And we found that in 52 patients who were initially observed with MEN1 asymptomatic non-functional adenomas, only 5 or 10% of those patients progressed on to need surgery over time, which, as a lot of you know, there's not a lot of natural history data with these pituitary tumors. And I think this is a pretty significant finding in that patients that have non-functioning tumors that we pick up incidentally on MRI exams for headaches and things like that probably have a low risk of progression if they're small. However, nonetheless still should be watched, and it's very probable also that spontaneous tumors may not act like this, but we know that in patients with MEN1 it's safe to observe tumors that are not causing problems. And this is a particular slide that says, if your first tumor of diagnosis with MEN, at the time of diagnosis, what do we typically see? Well, 82% of patients in our series had parathyroid adenomas at the beginning of diagnosis. Enterohepatic tumors developed in 74% of patients. Adrenal tumors developed in 19% of patients. Carcinoid tumors developed in 11% of tumors. Interestingly, the finding of pituitary tumor was a sole neoplasm was only seen in 5% of cases. So it's very common for someone to develop a secondary tumor type. If someone presents, as we said overall before, with the primary tumor type of being pituitary, the average age is 35.6, but more commonly we see people present as a younger age of parathyroid hormones, and that's really, or parathyroid adenomas, and that's really the hallmark of this disease. And then time to the second tumor given the first type. So if you're diagnosed with a parathyroid adenoma, very commonly that the next tumor type may be diagnosed by the time you're 14 and a half years later. However, with pituitary tumors, it's common to pick something up in the first year or two after that, and that should be kept in mind when following patients like this. Carcinoid tumors are much less. This pretty much suggests that when you have a carcinoid tumor identified, that a lot of the times you have another tumor identified associated with this MEN1 complex. And this is the likelihood of your tumor if your first of the second type of tumor if your first tumor is a pituitary adenoma. And what we see is patients, their second tumor being adrenal tumors in about 5.3% of the time, carcinoid tumors about 3.5% of the time, pancreatic tumors about 33% of the time, and again that very common parathyroid adenoma being approximately 60% of the time. And this, again, if you want to pause and find that you have a secondary tumor, so if you have a pancreatic tumor, what your most common associated tumor would be are in this table. And with parathyroid adenomas, I think it's important to notice that the most common secondary tumor are pancreatic tumors, but then again, pituitary tumors are the second most common when you present with a parathyroid adenoma. So, kind of getting back to the meat of the talk, and I realize this talk isn't going to run an hour. We're going to be winding down pretty shortly because it's a smaller subject than most. But so the treatment of adenomas and MEN1 really depends on the tumor type, and you can go back through a lot of the other PNI webinars here to kind of look at this. But as we stated, in those tumors that are not causing problems or are not overly large or overtly large, observation is very reasonable to do. Again, for incidentally discovered tumors. In patients that present with prolactinomas, and there's a clinical syndrome associated with that, obviously, cabergoline treatment or alternatively bromocriptine treatment are still the standard of care in these particular circumstances, and surgical resection only happens in those that develop CSF leaks, present primarily with CSF leaks, or are resistant to medical treatment or can't tolerate the medications themselves, which is uncommon. There are some other medical options for patients with growth hormone secreting tumors and ACTH secreting tumors, however, not typically the primary treatment for these. And then surgery, which we'll touch on a little bit, and sometimes radiation is involved as well. We'll just take you through, a common pituitary surgery, just so you understand if you're sitting out there with MEN1 and you're wondering about what pituitary surgery might look like or how that is. Well, pituitary surgery is done through the nose. We at the Mayo Clinic use an ENT colleague, and you can kind of look at a couple of our previous talks about that if you want to learn more about that. But come through the nose, they prepare the nose, and typically we get back to an air-filled area called the sphenoid, which this represents in this particular picture. What we see here is this is the pituitary gland after the bone has been removed and we're washing it off. These are part of those sinuses right here. The carotid artery is typically on one side or the other, on both sides of the pituitary gland. And here we're just washing it off before we open up this membrane around it. Here we're opening up dura over what it turns out to be about a 1.5 centimeter tumor in a patient with MEN1. We're going to slowly open up the dura meticulously, and we're going to dissect this away from what turns out to be a pseudocapsule. So this tissue that we're seeing in front of us is pseudocapsule. And we take our time to make sure that we understand our planes in this particular problem, right? I'm going to slowly open up that dura and dissect the way. And you guys have watched many videos where there's different ways of doing this. Some people like to resect all the dura on the front of the pituitary gland. Some people like to make an X. There's also other ways to go about doing this. Then we're going to dissect that dura away. First from the cavernous sinus, and then from the inferior aspect of the dura. Ultimately, we will open this dura a little bit more too. What we see here is we're starting to see the edge of the pituitary gland, and we're going to meticulously start to dissect that away. A lot of the times the pituitary gland is sitting cupped over the front of the tumor. And we want to make sure that we try to keep the pseudocapsule intact. We're just slowly and meticulously going to dissect this tumor. Now, this tumor is ultimately going to prove to be too large for our opening to remove it completely. So we're going to ultimately internally debulk this particular tumor. So here's that interface. And we're using an endoscope through the nose so we can see really well. Our ENT colleagues run the endoscope. And this little film of tissue right here, this is that dura, that's the top of the pituitary gland. I'm going to debulk a little bit of it. Send this off to pathology so they can tell us what kind of tumor it is. You know, is it plurihormonal, as we talked about, or multiple things within it? Is it just a tumor that we have that's just causing problems by compression? In this particular circumstance, this is a functioning tumor, which proves ultimately to have multiple different endocrine heart markers within it. And we're going to ultimately get behind that capsule of tumor. After we have it dissected, you can see a nice pseudocapsule right here. We'd spend some more time dissecting that. And bring that forward. Now, not always are these tumors this isn't a firm tumor, it's a little thick. Sometimes they're very soft, like cream of wheat. We can just suck them out and see the gland very well. You're going to see here that we have the pituitary gland very well intact. We're just going to take a little bit of extra pseudocapsule right there out. Just make sure we clean that up a little bit more right there, just to make sure we get everything. And then at the end, we're going to inspect the cavity. There's a posterior gland. This reddish tissue is the anterior pituitary gland pushed upwards. Sometimes we have to open up a little bit more than this. You can see here there's a little bit of a CSF leak sneaking around the front of the gland right here. We're just going to cauterize that together. Fill this with gel foam, and then take a little bit of skin from inside the nose and put that on there and put a little glue over it to close. But ultimately, this patient went on to cure and did very well. And in the end, I just want to thank you all for your time. I know this wasn't a long talk, but I just wanted to cover some of the aspects of MEN1. If you have any interest in coming down to see us, let us know. But thank you for your time. And Danielle, that's all I have.
Okay, thank you so much, Dr. Van Gumpel. We have no questions today. Everything was covered. Nobody has any further questions. So that will conclude today's webinar presentation. We appreciate you all taking the time to join us. If you missed any part of the webinar, or if you'd like to share it with family members or friends, it will be available on our website at www.pituitary.org after it is edited. And there will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. And thank you all for joining us, and enjoy the rest of your day.
Thank you very much.
Thank you. We really appreciate it.